Welcome, everyone. I'm delighted to welcome each and every one of you, the latest of Anna Freud Center's transformation seminars. The theme of our transformation seminars is thinking differently about mental health. The seminars provide a public space to explore and reflect on how we might think about the growing problem of child and family mental health. The seminars invite speakers to respond to a simple question: what is their idea to transform children and families' mental health in the UK? The seminars explore areas beyond clinical interventions, important though they are, to ask how we can think about, understand, and do things differently, individually, collectively, and as a society. Now, just before I introduce our wonderful speaker, a little bit of housekeeping. If you're tweeting us, please use our handle EFNCCF and use the hashtag Transformation Seminar. Our speaker will talk for around 40-45 minutes, after which there'll be Q&A. You can take part in this by sharing your questions in the chat function on your screen, and we will try our best to raise as many as possible of these questions in the time that there is available. Now, I'd like to extend a very, very warm welcome to my colleague, Professor Paul Ramchandani, who is leading today's seminar, Can We Make Prevention in Mental Health Really Work? Prevention is a key question for our time. If you can provide the right support at the right time, before mental health problems become apparent, we could reduce the impact on the level of suffering and the financial burden that is engendered by often complex and multifaceted treatments. Governments are understandably interested in this. Only today, we have launched our National Centre for Family Hubs, a program funded by the Department for Education, demonstrating evidence of strong, renewed interest in early intervention. But early intervention has become something of a cliche, a simple solution that ignores the complexity of both what it means and how it can be accomplished. If it was easy, why has it not already been implemented? Today's seminar will cover difficult questions about the hard truths and challenges that we must face if we are to fully embrace the reality of early intervention and prevention. These are some of the themes that our outstanding speaker, Professor Paul Ramchandani, will explore. Paul is one of the world's leading authority, I would say, on play without competition. He is Lego Professor of Play in Education and Development and Learning at Cambridge University. He's director of the Parental Research Centre, where he leads a research team investigating the role of play in children's early development. He also works as a consultant child and adolescent psychiatrist in the National Health Service. His leadership, his experience, his enthusiasm has enriched our understanding of the great importance of play in early education. Paul trained as a doctor in Southampton and then as a child and adolescent psychiatrist. But he also took a degree in public health from the London School of Hygiene and Tropical Medicine, before going on to study for a doctorate at Oxford University. Prior to taking up his appointment in Cambridge in January 2018, Paul led the Child and Adolescent Mental Health Group at Imperial College London. Paul's research focuses on early child development. He's has a particular interest in child and parental play, but linked to this, the prevention of emotional and behavioral difficulties. His work has explored the role of fathers as well as mothers, their role in children's lives, and it includes the development and testing of innovative psychological intervention, but also wonderful detailed observational studies of parents and young children. I'm absolutely delighted and privileged and honored to welcome him to give his transformation seminar. Prevention is a subject we all need to think about much harder. And I'm really looking forward to the insight Paul Ramchandani can bring to this challenging subject, title of which is, Can We Make Prevention in Mental Health Really Work? So Paul, can we?
Thank you very much, Peter. And thank you very much for that kind introduction. I'm going to be speaking primarily about mental health, so with my kind of child and adolescent psychiatry hat on, although there is overlap with play, and you'll see that will come up at points. It's an absolute pleasure to be here, especially on this day where we've had such a positive launch of the National Centre for Family Hubs. That's wonderful news. And I want to share some thoughts. As Peter alluded to, this is difficult stuff to get right. So it's not that I'm going to give you all the simple answers that have been hidden for so long. I'm going to share some of the dilemmas and some of the challenges that we face in my slides. Thank you. So I'm going to share an idea. I'm going to share some findings, and I'm going to share a challenge represented by these three images: an idea, some findings, and a challenge. When we think about prevention in mental health, I think we've got a lot to be glad and very positive about, as well as some things to be concerned about and some challenges to face. And I'm going to focus on two areas. So have the next slide, please. I'm going to focus on the case for prevention. And here I think we have some good news and some good truths in our field. And I'm going to spend most of the talk this evening on this. But secondly, we need to be searching for potential solutions. How do we do better? We're clearly not solving the problem of preventing mental health problems, if it could ever be completely solved, but there's a long way to go for us to feel like we're really getting to grips with it in the way that we should. And the potential solutions raises some hard truths and is more difficult. Next slide, please. Thank you. So I'm going to make 2 points on the case for prevention. Intervening early can make a powerful difference to life chances, and we have many of the tools to do it well. On the potential difficulty, solutions, and hard truths, I'm going to come to that we need to think about how we knit interventions together across childhood better. We're quite good now at identifying interventions that can be helpful in different circumstances with different groups of children and families, but how we put that together to support the families that need support throughout childhood is a challenge, and one that I think is a really important one for us to take on. And then the second hard truth, that actually, and I'm speaking here as a member of the kind of child and adolescent mental health profession or the infant mental health profession, a lot of the work of prevention actually is the work of others, and we have to think about how we address that as a field. Next slide, please. So this is from the Early Years Healthy Development Review report, came out earlier this year. The building blocks for lifelong emotional and physical health are laid down in the period from conception to the age of 2, and we don't give this critical period the focus it deserves. And that's something I absolutely sign up to. It's a really, really important period of life. It's not the only important period of life and development, but it's a really, really important period of life and development. If we have the next slide, please. This will be a slide that's familiar to many of you if you're in the field of early intervention. The Heckman Curve. So showing across the bottom, across the x-axis on the bottom, children getting older from the prenatal period through to post-school. And on the y-axis going up the side, the rate of return of investment human capital. So what this slide is making the case for is that if we intervene early, we actually get a better rate of return than if we intervene later. The The data doesn't all support this. This is a schematic. This isn't, although it's based on data, it's a schematic of that data. But subsequent data has challenged whether this curve really stands in the way that it does. It's not to say that intervening early is wrong, and it can be really, really helpful, but actually challenging the idea that intervening later is less effective or has less returns. So this is a challenge, if you like, to the Heckman curve. And all of us who work with not only infants, but also older children and adolescents, I guess, know, or at least hope, that what we do does some good if we think about mental health services. So this curve presents a natural challenge, I think, to those of us that work across childhood, and doesn't quite ring true for many of us, in that we know intervening early is important, but intervening later can also be helpful. But the curve is helpful in that it does point to the importance of early years. And if we intervene early, we can set things off on a positive train. I want to take a slightly different way of looking at this now. Not saying that intervening early is problematic, but thinking about where early intervention sits in that. So if I can have the next slide, please. So this is just a really simple schematic. Along the bottom, you've got a child getting older through life. So from conception through 2 years, 4 years, and through to adulthood. And then on the y-axis going up the side, you've got functioning, and that could be many different kinds of functioning. Let's take behavior, or behavioral difficulties as one example, but it could be anything. Now, if a child is progressing at average, it will move across from the left-hand side in the middle all the way along on a more or less straight line if it's staying average with all of its peers. And what I'm showing here is a child where some positive things have happened to this child. So they start in the middle, but you can see at various points, there are slight inflections upwards and bigger inflections upwards when they're age 2. And this change of direction could be something happening for good or for ill. But in the case of this particular child in this particular line, this is for good. So you're seeing things like perhaps they made a new friend or friendship groups, perhaps they got into a particularly good school, perhaps there was something that happened within their family that was a very positive experience. And this child has thus moved from average going up and up to functioning much better than average across the course of their childhood. We all start at different places on the line at the left, and we all go in different directions. So if we move on to the next slide and add in another child, and this might be a child for whom things start at the same point, but they have a different trajectory. Maybe they experience some adverse events when they're just after 2, and then again into later childhoods. Maybe they experience bullying, maybe they end up in a school where they're really, really struggling. Maybe they experience maltreatment. It could be a range of different adverse events. And so you see from the same starting point, children can go in quite wide different directions. And if we go on to the next slide, please. So most children are likely to end up in this range with the 2 outer lines, depending on a mix of their own characteristics and opportunities at the start of life, but also, importantly, what happens to them subsequently. And of course, the mix between those 2 things happening. And this is the range of possibilities, these outer limits, the range of possibilities. And if we go on to the next slide, please, this is what I'm calling the funnel of love, if you like. We can think of it as the breadth of possibility that is possible from a child when we start at conception and we look ahead to what might be possible for them in adulthood. And as I say, the functioning can be a range of different, can be thinking about cognitive development, can be thinking about their educational attainment, can be thinking about their behavior or their emotions. These are the range of possibilities that is possible for that child. And obviously, as interveners, we're looking to, as people working in the field, we're looking to maximize the positive. So if we now move on to the next slide and think about what happens if we intervene just a little bit later. So if we start at the age of 2 years, we still have a huge amount of possibility. The kind of width, the direction of the lines is still in the same direction, but the full range of possibilities is a little bit less when we get to the end, if we're intervening later. So the funnel of love, if you like, is narrower at the end. And then if we move on to the next slide and intervene later still, we're still going in the same directions or same possibilities, but the range of possible outcomes for good and for ill is less for the child. And you can see that if we put these all together in the next slide. If you look on the far right-hand side of this slide, you'll see if we start intervening at the age of 4, we've got a range of possibilities represented by the small orange arrow, which I hope you see as orange. I see it as orange, but I'm not very good at colours sometimes. Whereas if we can intervene earlier and start at conception, we've got a range of possibilities that is represented by the bigger arrow. And you can see the stark difference there. What's important, I guess, is that interventions at all ages can make a difference. You can see there's possibility for making a difference throughout childhood and throughout life. But the chance to make a really big difference in later life is less the later we leave it. If we can move on to the next slide, please. So the potential is great, and the earlier we get in there, the better, the bigger the potential is for us to be able to support and help children. And the rates of mental health problems in this country and many others suggest that, boy, do we really need it. We need to have early intervention and prevention services. This is showing data from the national surveys. This is taken from a publication. The data is taken from a publication by Tamsin Ford and colleagues early this year. And you can see this is the rates in the national surveys, rates of mental health problems in young people. I think this is a 5 to 16, 1999, around about 10% of young people had a probable mental health problem. That crept up to a bit over 11 by 2017, and it's carried on creeping up since. And then 2020, that's the pandemic, and probably a significant pandemic effect. But the trend overall is upwards. So we're not getting it right. We're doing as well as we can in terms of helping these children when they get mental health problems. We're not getting it right in terms of preventing them from happening. If we can move on to the next slide, please. So we have many of the tools that we need to do it well. There have been real advances, and I certainly don't want to downplay them. Our understanding of early infant development and the importance of early relationships has increased enormously in the last few years, and we have quite a lot of the evidence that we need. And at the start, I said I was going to share an idea, which was the funnel of love idea. I'm going to share some findings now. If we move on to the next slide, I want to share a couple of pieces of research from the early years that have come out this year. And the first one in particular, I think, came out a bit under the radar, partly because we were still in the middle of a pandemic. So I want to share some findings from the Family Nurse Partnership follow-up study, and also from a newly published trial of video feedback, which, along with colleagues at Imperial and other places I was involved in leading. So if we move on to the first slide, this is from the Family Nurse Partnership. Now, many of you will be familiar with the Family Nurse Partnership trial, that building blocks trial that reported some years ago. They've been able to follow up these children now to the age of 7 using routinely collected data. And these findings are interesting. So this is, you can see the full reports published in the NIHR library. The references in the bottom right-hand corner. Michael Robling and colleagues. So they didn't find any differences on maltreatment and some of the other child in need outcomes they were looking for, but they did find differences if a child had been in the Family Nurse Partnership on early educational attainment. So this is early learning goals. And in the middle column, I'm sorry, I can't point to it, but in the middle column, you can see that there's the adjusted parameter estimate. You see improved outcomes in the children who receive Family Nurse Partnership intervention compared to usual care. So this is promising. It's disappointing in a way, I suppose, that the Family Nurse Partnership study didn't find effects on child maltreatment and some of the other things that we hope and many of us believed it had impact on, certainly did in the early trials in America. But within the UK setting, we are seeing some potential benefits for early education attainment, and that seems to be quite a powerful signal. And I want to spend a few moments just telling you about the findings from the Healthy Start, Happy Start trial. If we move on to the next slide, please. So this was a randomized controlled trial, which was aiming to evaluate the effectiveness and cost effectiveness of an intervention called VIP, which is video feedback to promote positive parenting. And we designed this trial to see if it would prevent enduring behavior problems in very young children. So we deliberately went younger than most trials do when they're thinking about behavior problems. And that presents its own challenges, which some of you may have questions about. So we recruited children who were aged 1 and 2 years old, so 12 to 36 months old. Next slide, please. And this was to test video feedback intervention. That's a brief 6-session intervention, which was developed in the Netherlands by Femi Juffer, Marian Backemans-Kranenberg, and Marina Svan Eisendoorn. It's an interesting intervention. It's a very positively focused intervention underpinned by attachment theory and social learning theory. So it brings elements of those two things together to try and improve parental sensitivity, but also to give parents some skills to manage difficult behavior in young children. It's 6 sessions, which are approximately fortnightly, every 2 weeks. And in each session, there's an element of filming and an element of feedback from the previous session. So parent-child play and interaction, and it's mostly play, is filmed, and then the intervener takes that video away and looks at it and looks for particularly elements of positive interaction where the parent is noticing a child's signal or behavior and responding appropriately to it in a timely way. So sensitive, responsive, if you like. So this intervention tries to build on that. We picked this intervention to study for this problem because at the time, it was the one with probably the best evidence base in terms of trials from mostly the Netherlands. If we move on to the next slide, please. We did a randomized controlled trial. So 300 people were recruited. They were randomized to either receive these 6 sessions of video feedback or to receive treatment as usual, the right-hand column. And then we were able to follow them up at 5 months and then again 24 months later. And that second 24-month follow-up, the children were then aged 3 to 5, mostly 3 and 4 years old. Thank you very much. The families were recruited from a range of mental health and community trusts in London, so CNWL, Whittington and Nelft in London, and then Hertfordshire and in Peterborough and in Oxfordshire as well. So across a fairly broad range of populations within London and out in the wide periphery of London, if you like. Next slide, please. And at all time points, we did a range of different assessments. I'm just going to draw your attention to the one at the top because that was the main one. And we pre-specified that we'd be looking at children's behavior using an interview measure. So this is an interview that's rated by the interviewer. So it's based on parents' reports of behavior, but they're ranked and rated by an independent interviewer. And then we had a range of other questionnaires that looked at children's behavior, also parents' mood and anxiety, and we videoed parents and children playing in a variety of settings as well. Next slide, please. At the second year follow-up, we were able to include a few other things. I'm just putting this up here mostly for information. So we were able to look at children's executive function, look at their emotional reactivity. We were able to look at how children view things themselves using story stems, which I haven't got time to go into today in detail. This is a bit of the work that's led by one of my colleagues, Beth Barker, along with Christine O'Farrelly. But I think it's really intriguing that we get to see how children view stuff themselves, as well as the usual parents' report of behavior. And we've also got consent to link to the National Pupil Database. So we're hoping next year to be able to do something along the lines that the FMP study did, be able to look at routine educational data as well as routine health data. Next slide, please. So this is just to show you quickly the Doll's House play. So a variety of stories are set up, and then the child acts out the story, shows us how they think it will work out. And through this, we're able to get a child's eye view, if you like, of their world, encompassing behavior, friendships, and relationships. Next slide, please. This is just to show the primary outcome of the study. So this study is finished now. We followed all of these children up. We had about a 94% follow-up rate. And this is the finding from the main primary outcome time, which is 5 months follow-up. And if you look across the columns, the second column you come to is the VIP group. And as you look down, the mean score for behavior goes down from 33.54 to 28.8. And if you look in the next column at the control group, the behavior score does go down as well, but by less. So it goes down from 32.4 to 30.3. And the difference is shown on the right. So you've got a 2-point difference on the pre-PACT scale, which approximates to the kinds of questions we were asking. So it might make the difference between a child having a tantrum more or less every day to having a tantrum about 2 times a week, or the difference between it being a very severe tantrum to being a relatively mild one. So that 2-point difference does relate to a fairly clear difference in behavior as noticed by parents. And next slide, please. We were interested to see if there was a difference for the youngest children. I think most of us are familiar with interventions for behavior at age 4, 5, 6 and upwards, and there's quite a lot of evidence that those tend to work. But going in to see 1 and 2-year-olds, there's a lot more uncertainty. And so what we have in the right-hand column here is the top number is the score difference for 1-year-olds, and the bottom number is the score difference for 2-year-olds. Those numbers actually overlap quite a lot, but I think what we can say, the number at the top is bigger. So there's no evidence, certainly, that this doesn't work in younger children. If anything, it seems to work better in the younger children. But I wouldn't say that with huge confidence because of the overlap in the numbers. And if we move on to the next slide, please. And then we followed up these children 24 months later when they're aged 3 and 4. And what you see here are, I've got a green and a purple line. I hope you've got something similar. The purple line is the control group, treatments as usual group. And you see a baseline over on the left, and then 5 months in the middle. By 5 months, you've got the VIP group scoring about 2 points less than the control group. And that difference is sustained pretty much unchanged. It diminishes very, very slightly, but you can see as the eye looks at it, not much difference as you go through to 24 months. So we've got, if we move on to the next slide, please, some good news from those studies, even just from this year. So that's evidence just from this year. We've got sustained effects of 2 early interventions, family nurse partnership right through to the age of 7, the VIP intervention through to 2 years later than the intervention, so age 3 and 4. And we have more. We've got ongoing trials of prevention and early intervention. We've got the COSY trial led from the Anna Freud Centre. We've got a range of other service developments in infancy and early childhood. And we have a lot of this collated and thought about and presented in coherent ways by organisations like the Early Intervention Foundation. So we have quite a lot of good news. Move on to the next slide, please. I'm now just going to spend the last few minutes of my talk focusing on the second group of challenges, if you like. So I've given you what I see as the good news. We can make a big difference early in life, and we've got a lot of the tools to do it well. We're still not there yet. That slide showing the rate of mental health problems in children shows what a big challenge we all have. So a couple of things on potential solutions. So first of all, thinking about one-off interventions probably not being enough on their own. They do make a difference, but the same children are often the ones who might get into difficulty. And we need a system that we can knit together different interventions across childhood. If I have the next slide, please. So this is the slide I showed earlier on. It's just thinking about putting a system together. And each of these points of change, as we look across the slide, each of these changes in direction is a point where we can make a difference. And so we might have a child who starts by being in the family nurse partnership program, who then perhaps moves on to a different intervention, like a video feedback intervention at the age of 1 or 2 years, and then might later on go on into some other kind of psychological intervention, perhaps incredible years, or some other form of intervention. So I feel like there's a lot of thought. I think there's a lot of thought that needs to go into thinking about how we put these systems together for different groups of families, some of whom will be very high risk. And then the last point I want to think about is our approach. Could I have the next slide, please? And this is the last point about a lot of the work of prevention is the work of others. So this is taken from the work of Jeffrey Rose. This is a population approach to thinking about risk reduction. And when we work in child and adolescent mental health services, and I include myself in this, we're often focusing on the high-risk group. So if we look at the right-hand bell curve, so normal curve, the one coloured in green, with the red on the right-hand side. This is a normal distribution of, can be any characteristic, any risk factor that we might like to think about. They're not all distributed normally, but many of them are. So if we just think about risk factor, it might be poverty, it might be bullying, it might be some other risk factor. We often focus, and when we think about early intervention, we often think about the high risk group, and it represented by the red colouring in here. But what we know is that in the high risk group for many things, the risk of increases, their risk of a bad outcome is higher. So the risk of a behavioural problem may be higher than the rest of the population, but actually the rest of the population also has a risk. It may be smaller. So say, for example, the risk of developing a behavioural problem in the general population was 1.5. In the higher risk group, it's 3, so twice the amount. But because that high risk group is a small part of the population, actually most people at risk of developing a behavioural problem will be in the green area. So if we only focus on the red area, we're going to be missing the vast majority of people who might go on to develop a behavioural problem or another kind of problem. And so the solutions that we seek, if we really want to make a difference to the population risk of mental health problems, have to be thinking about population approaches as well as high-risk approaches. Because if we only take high-risk approaches, we're going to miss the vast majority of the difficulties that are going to arise. And this can be thought about in terms of not only the risk factors that we think about, say poverty, bullying, many of those kind of social risk factors that are the big ones for mental health problems, but also thinking about how we approach positive factors. So community factors that give children the best chance in life, improving the range of parent-child, the positivity of parent-child interaction across the piece, not just for the most challenged or disadvantages, and thinking about interventions that make life better for children. So things around play, outdoor activity, exercise, encouraging friendships, all of these kind of positive aspects to life and aspects to intervention. So this is a challenge, I think, for many of us in the field, because we are focused on high risk. The people that we see tend to be the high risk. If we want to make a difference to the population risk for mental health problems, we need to think about partnering with other people who take different approaches and who can have leverage on some of these other risk factors that we can't touch so easily as child and adolescent mental health professionals. And if we move on to the last slide, this is my concluding slide. Thank you. So I started with what I think is good news, and I think that any of us in the field can be proud of some of the achievements that the whole field has managed. So we've moved forward in our understanding of the importance of the early years and the importance of infancy and early childhood in thinking about children's development and risk for mental health problems. We've moved forward in developing and testing interventions. So we know we have some interventions that are effective in some circumstances. And we certainly moved forward in terms of better models of service delivery. There's still a long way to go and it's patchy, but we have a much better understanding, and Anna Freud Centre's certainly one of the leading centres in this, and made a huge contribution in terms of thinking about that, how we deliver services and what we deliver. But prevention is not really a therapy-shaped problem. It's not really a tablet-shaped problem. I'm a psychiatrist. It's not even really a CAM-shaped problem. We need to be thinking about that whole population shift and how we manage that whole population shift if we want to make the biggest difference to children's mental health. And that's not saying ignore the kids with difficulties or the kids at risk. We do need to address those risks and those difficulties. But if we want to make that big change, we need other levers. And so I'd leave you with a challenge. I wish I had all the answers to this, and I don't, but I think it's our time to focus anew on those alliances for children's health and development, putting children right at the centre of policy making at the local and the community and the national level, so that when decisions are made about spending, decisions are made about interventions, they're made with children in mind and not with children as an afterthought. And on that note, I'm going to stop. Thank you all for your attention. I'm sorry for the little glitch in the middle, where I wasn't quite sure if I was still transmitting, but I'm still here.
And we are delighted that you're still here. And that was a delightful talk. Well, thanks so much. And this was also, I think, delightful in the sense it was very accessible, and even I could understand it. And I've only been working in this area for 40 years, so I'm absolutely delighted with what you had to say. I mean, it seems to me, Paul, you're making two fundamentally important points. One is that whilst interventions work, they're in the context of an individual's life. All the other things happen to them, and they got to be integrated with everything else. that happens. Otherwise, they are not going to have the outcome that you hope for, particularly as the child's life rolls on. And the second is that by focusing just on the those that are at highest risk, you're actually not reducing prevalence, because prevalence remains the same, because the biggest chunk who actually are going to be experiencing problems haven't been addressed at all. And it seems to me these are really, really important points. I think I have lots of questions, but first of all, before having my questions, I just want to raise some of the ones that have come through so far. Okay, some are different from what you were expecting, but I'm not going to protect you from them. Okay. Thanking you for the presentation, but what can you tell us about the phenotype of schizophrenia in childhood related to, related to outsider issues? So, what's the phenotype? How can you intervene, I guess, with the phenotype like schizophrenia? Can you make it? Is there any evidence that you can make any difference that you know of?
Gosh, starting with a very challenging one. So I start with a disclaimer. I'm not an expert in schizophrenia research, so I can share my general kind of knowledge, but it's not a field that I am absolutely in the middle of at all. I mean, one of the really interesting things I think over the last few years that I've noticed anyway, when I was training a few years back, the story was of the neurodevelopmental hypothesis of schizophrenia. So thinking about a genetic and developmental kind of constellation that then came out in later adolescence. I think one of the really interesting changes in the field over the last probably 10 years has been the recognition that life events and trauma in particular, and maltreatment in particular, play a role in the generation. Perhaps much more in people who are at risk for other reasons, but that these things have a significant interplay. So I think if we're thinking about what can we do to intervene if we want to prevent schizophrenia, I think it's a very difficult challenge. It's a relatively rare condition. It's a relatively heterogeneous condition. So I don't think there's any one point, but it does overlap with the general point about trying to make sure that children have the best start in life and the best opportunities in life. So one thing, if we can and if we could, is thinking about reducing the risk of maltreatment and abuse, because that will have an impact on the development of those children, but also others. So it's a slightly non-specific answer to the question, but I suppose it's picking off one of the factors that might.
I'd like to come back to that. I allowed the question through, but allowed the question. I wanted to bring the question to your attention because it raised an issue about genetics, about predisposition that you haven't touched on really fully. But we can come back to that, and maybe I'll force you to come back to that. But let me just bring some of the other stuff. Well, what do you think can be the role of mental health support teams? Should they be expanded?
Sorry, can you repeat that? Sorry, I didn't catch that.
Mental health support teams. Should we expand the role of mental health support teams, say in education, setting up mental health support teams, linked to schools? Should they be also involved at the moment treating mild disorders? Should they be involved in prevention? Yeah,
that's a really interesting question. And I'm sitting, I guess, with lots of people waiting to see what happens from that intervention. I think that particular service configuration. I mean, I think there are huge advantages in having some relatively specialist provision where children are, and school's obviously the place where children are. But there are challenges to that as well, thinking about stigma within the schools and children access, some children will access services there, some will experience problems. I think it moves some way when I was talking about the prevention paradox at the end and that normal curve. It moves some way to addressing a broader spectrum of difficulties. So the thing that I think is potentially really, really encouraging, linking in with what I was saying, is that those people with some specialist knowledge and expert knowledge can help schools to think about mental health problems in the round and what the school can do to intervene. And to be honest, I wouldn't be surprised if that ends up being one of their biggest effects. I know there's individual treatment and groups and so on being offered, but that ability to shift the culture within the schools and support schools in how they can address broader factors that can affect mental health, for me, is one of the really positive, encouraging aspects of that intervention.
You may well be right. I wouldn't.
I might be wrong, but that's why.
Yeah, I wouldn't want to bet against you. More closer to the major theme of your talk, Paul. How do we? Are there examples that you can bring to us that would help us understand better? How can services be better knitted together? How can health and social care be operating better, for example, under one roof? Are there any trials that you know where this has been implemented?
Gosh, not off the top of my head. From your smile, I wonder if you might know one, Peter. But off the top of my head, I can't think of trials that are looking at those kind of service configurations. Do you know of any? I know I'm not supposed to ask you questions.
Yes, I know. But it's in fact it goes to Michael Porter's integrated practice units, wherein there is a great deal of good evidence that integrating practices makes them more efficient and more effective. There is, but the point that you make about knitting together is so important. How would you knit together health and social care? What would your 5 top tips be? Maybe 3 top tips.
Well, maybe can I take the question a slightly different way of thinking about
it?
Because I guess I was thinking about knitting together of provision over time for children and families. So the knitting together of different services so they work seamlessly, I think, is really, really important. But what I was thinking about was that often some of the similar children present with problems at different ages through childhood. And our approach as researchers anyway, or the approach that I am certainly guilty of as a researcher, is we get very excited by a particular intervention at a particular point in time, and we do a trial and we find that it works, and well, hey, that's great. Your point about the context being important I think is hugely important. That we think about the context and we try hard to think about the context, but we're looking at an isolated intervention at one point in time, and that can inform, but it's not enough. And so there can be a variety of ways in which you can think about it. I gave a very kind of simple one, thinking about the same child progressing through different interventions with their family as they needed it at different ages. But we could also think about, well, what kind of service provision might support that? And in mental health, obviously, once children get into a service like CAMHS, they potentially can be there for a number of years. But the model over the last few years has moved away from that. It's been much more episodic. And I guess there are efficiencies in that, but there are also some problems in that, because some of those children we just know will come back. Are likely to come back, and we haven't solved their problems with episodic care. One model, I guess, when it works optimally, that we do have in healthcare is health visitors. So where it works well, you have one or a team, small group of health visitors who will care for a particular child and family through the first years of their life. So we have a model where things can be provided by health visitor teams through these early years, if we can get the right kinds of intervention and the right kinds of work in. So there is a model, I think, that can work. It's not an explicitly mental health model, but I think it's a model that we could think about working with much more effectively as mental health practitioners.
Okay, so that's a really good answer. And I really, really like that. Let me give you another, because you did so well on that. I'll give you a more difficult one. Does the particular intervention that you've tested, the one that has been developed in the Netherlands, include all young children? For example, would it work with young children with neurodevelopmental conditions and disabilities? What's the evidence there?
Yeah, so I mean, there's a broad grouping of video feedback type interventions. There's VIP and there's big, and there are others as well. So there's if we think for a moment just about research findings and trials, and come on to practice in a moment, but think just about research trials. There have been trials of interventions that are very similar or overlapping for children with autism and their families, and the benefits. Jonathan Green and colleagues in Manchester and in collaboration with others across the country, but also in Australia, there have been trials where these interventions do seem to hold promise. We targeted particularly children at higher risk of behavioural problems, partly because that's a way of looking at that particular set of problems. But there are elements of video feedback that I think could be helpful for many, many parents, because it's a positively focused intervention. It picks up on normal interactions, and it offers parents the chance to stop and reflect and talk with a practitioner and see their own behaviour and their own responses. And very, very critically, the bit that comes across, I think, well, certainly in some of the pilot work we did very powerfully, is that parents can notice their child interacting and looking at them and taking signals, and taking value from them and noticing them. And that can be very, very powerful for any parent, particularly of a very busy toddler or a very busy baby, to have that and see that and notice that they're important to their child and what they do is important to their child, feels to me like a fundamental truth that most of us as parents could do with. I certainly missed it when I had young children. Life was so busy and so kind of so hemmed in with trying to look after young children that you just don't notice all of those things. You do the best you can. But video feedback, I think, really can be helpful. And that doesn't necessarily have to be a formal intervention of a particular length. There's some general stuff in there that I think is very, very powerful and very, very helpful to a wider range of people. Obviously, if we're thinking about intervening for families who are having difficulties, we need to think about kind of more organised treatments and particular models of treatment. I think there are some elements of it which are almost universally helpful.
It's remarkable that a brief intervention, a 6-session intervention, can have an impact many years, but a number of years down the line in your study. And it's hard to imagine that happening unless it actually profoundly changes the way the parent behaves with the child. That it does something that's much more than those correcting a few mismatches, but gives a way of, for example, recovering from ruptures in the relationship between the parent and the child, and focusing on. So it's I think people might have missed the remarkable 6 sessions. It's nothing. And yet you had these really powerful effects.
Yeah,
really, really impressed.
The therapists who delivered it will be much better able to talk to this than me, really. And I know at least Stevens from the Anna Freud Centre on this webinar, but there'll be others as well. I think you have to assume that it generalises, that some of the elements that people learn in those sessions generalise to their behaviour outside of those sessions. So there is something in that, and it probably applies to other therapies as well. But in this trial, we've seen an effect. So it must generalise to how the parent interacts with the child, and as you say, maybe it helps to start the process of mending some ruptures, but also allows them to interact in different ways in their general life with their child.
Okay, now this is another difficult one, Paul. You're getting the most difficult questions. I'm trying to get the easier ones, but they're just so difficult.
I'm saving up my passes and my I don't knows.
poverty, we know, is a major determinant. And maybe part of that is in terms of adverse childhood experiences that impact on those who are in more challenging economic conditions. What can we do to support the families who do not quite meet the criteria for child and adolescent mental health services, and yet who we see as having adversities that we know might well lead to poor outcomes?
Yeah, I mean, this is a challenge for society, isn't it? It's not something that as individual practitioners or even groups of kind of health professionals we can necessarily solve, but I think we have to be thinking about how we can contribute so that those people who do make these decisions really understand. And you know, you do a lot of this with politicians and others, but we have to find a way of putting the importance of children at the centre of decisions that are made. Absolutely, and it's missing at the moment, it seems to me. I mean, we have raised the profile of children's mental health enormously. I say that at the Royal We, that's not me, that's the field, and individuals within it have done an awful lot, and that's been very, very successful. But I think some of the links to inequalities, you know, Michael Marmot's work just kind of tells us the story again and again and again. Inequalities are corrupting of everything. Children's physical health, children's mental health, adults' mental health, adults' physical health. And we need to address those. We need to think of ways of addressing them as a society. So it's a challenge that goes way beyond us, and I can talk in very great generalities, but I don't think it's necessarily helpful. But I think what my final call in my talk was that we continue to think about how we more effectively raise the voice of children so that they're heard and what they need is heard at the national political and the local political level, because it's just missing too often.
Thank you for that. We could come back to that. I'd be really interested in exploring it further, but there's another question, another difficult one. This questioner felt that there was an elephant in the room, and that elephant was the effect of parental mental illness. Is there are practical situations about that, practical difficulties when child mental health professionals are not able to access information in relation to the parent's mental illness because that's regarded as confidential information. How do you tackle, in a kind of prevention point of view, that really complicated situation?
Yeah. Well, there are challenges, and it comes back to your point about joining up. You know, yeah. There are real issues of confidentiality, and that can present real obstacles if you're working with a child and you don't have a full picture of what the difficulties are that parents facing. That obviously makes your job much, much more difficult. In terms of prevention, I think some of the same principles still apply. You know, people, if they have depression, if they have anxiety, if they have schizophrenia, if they have other conditions, they still have some of the same core needs as parents and some of the same core challenges as parents. So we may need to adapt our interventions. We may need to add different elements into our interventions. A really nice example of this is work that Kirsten Barnicott has been doing at Imperial and now at City University. So she's using video feedback techniques with parents who have particular challenges, kind of emotional control challenges. Sometimes we describe as kind of borderline personality disorder type challenges. I'm never quite sure what to make of that term, but those kind of difficulties where they have difficulties in emotional regulation that are quite severe. And she's been able to adapt the video feedback interventions, and it has needed an adaptation to kind of help those parents to engage. But it's still at its core trying to do the same thing. So I feel slightly uncertain about how much we should worry about changing what we do for prevention, specifically for mental illness. Not that it's not important, and it's a huge difficulty that families face. But some of the same things and some of the same supports are going to be the things that we need to do, and we may need to adapt them, probably more on an individual level than a kind of groups of people level,
This takes me, sorry.
It's a really difficult problem.
It is. But as I said, if I had an easy question from here, I would ask it to. But there's another really quite challenging one. And this is one that I have some sympathy with. Say that there is a non-traditional, innovative, preventive solution that somebody proposes. But when you did your prevention trial with VIP, you took something that had a strong evidence base already. But how can something that may be really effective but is non-traditional, is outside the mainstream, how can that acquire the evidence base that it would need in order to be adopted within mainstream interventions?
Yeah, no, that's a good question, and it's a very common challenge, isn't it, in our field, that kind of innovative ideas come along. I'm a real big fan of trials, and although it aged me significantly, I really enjoy doing that particular trial. But they're not the only evidence. I guess we have to be careful when we're thinking about work with children and families, because anything that is potentially effective used in the wrong way or the wrong situation could potentially be harmful if something is effective. There are a few things that are good everywhere all the time. So I think bringing those things into the mainstream, I guess, would be thinking about the balance of, well, what can you collect in terms of routine outcome or outcome data that helps to support knowing whether this works or not, but also being careful to make sure that there are no harms anticipated or otherwise associated with it, and then gradually accruing that information, that clinical information, and then thinking about what's the most appropriate form of evaluation. And it might be a trial, but it might well not be. I mean, as well as I do, trials have their drawbacks. They take forever. And if you want something out there, you wait for a trial, you're going to be waiting 5, possibly even 10 years. So that's a significant challenge. I say I'm a fan of randomized controls. They have huge advantages, but they have drawbacks as well. So thinking about different forms of evidence, but collecting real information about what's gone well and what's gone less well, I think is absolutely crucial.
Okay, I've got some more questions. In fact, I'm just started getting worried that we won't have time for all of them.
I've got 48 listed on the bottom, Peter. We haven't got time for those.
What are the factors which could show greatest potential for shifting the population distribution as you were recommending?
The big ones are going to be societal ones, which I'm going to start sounding a bit like a stuck record, but underpinning a lot of the things that we see are going to be things like poverty, inequality, and precarity is a difficult word, but that kind of sense of families living on the edge with uncertainty. I think we haven't been able to, or I haven't been able to think of ways of studying it very well, but it's a huge generator of anxiety. And, when people grow up and they talk about the things that felt difficult in their childhood, they talk about lots of things, but one that often comes across as a sense of worry and anxiety that's in their family. And that could be because of poverty, material poverty. It could be because of unpredictable parents. It could be because of worry about some other form of adversity or maltreatment. But that sense of worry in young children and precarity, that things are not quite safe, things are not quite okay. And that extends to broader society when people don't feel secure in their jobs, don't feel secure about their future. That precarity that we feel as adults communicates itself to children in all sorts of ways. So that's a difficult one to define, but I think it's a really important one as well.
This is a challenging question again, but one that I think you really should try and answer. Do you have a theory of change for achieving change in parent-child relationship? For example, is that theory of change in terms of attachment? Or what is your theory of change?
Yeah. Well, I start from a position of attachment. That those very early relationships are actually absolutely fundamental to people's sense of security or lack of sense of security, and that's fostered at least in part by sensitivity. I mean, we focus almost exclusively on sensitivity sometimes, and it's really, really important, but there are other elements that are important to those early parent-child interactions. So one of the bits that often gets missing is the sense of encouragement and safety and exploration, which is the other bit of attachment, that children feel safe and equipped to go out and try new things. So that exploration bit is important. It's obviously linked to sensitivity. And then in play, we're thinking about a range of other elements of interaction. So positivity and positive mood and positive activity within interactions is another component. So I guess for me, the fundamental kind of picture of attachment and security and sensitivity is the starting point, and it explains a lot. It doesn't explain everything, but explains a lot. But there are these other elements which I think as a researcher are really exciting and interesting to be beginning to explore and beginning to think about.
Following on from that, would you agree, or do you believe that parents should be better educated on how their behaviors, how their actions can impact on a child's emerging mental health or mental well-being? This is moving the population.
Yeah. So I think parents learning about the impact that their actions and that they can have on their child is an important thing. I'm not sure. I think we have to be careful about how we frame that. And my preference, I guess, in most cases, is to think about how we frame that positively. So about how parents can have significantly positive effects on the children's development rather than necessarily focusing on the negative. It's not that focusing on the negatives is a terrible thing to do, but I think there are risks attached to it. And particularly if we're thinking about people who are maybe more vulnerable or may have more negative views of themselves, giving them information that they're somehow harmful to their children or somehow detrimental to their children can be harmful. So, and we see this in interventions in pregnancy. So thinking about parents with anxiety, there was a little spell going back probably 10 years ago where there was a lot of research around parental anxiety in pregnancy, maternal anxiety in particular, and how it was linked with increased behavioural problems in children, as you'll know well. Sometimes that leaked out into the kind of wider ether as if you're stressed in pregnancy, you're damaging your child, which, one thing guaranteed to make people more stressed is tell them that by their very being stressed is going to be damaging. So that's one of the reasons why I'm very cautious about kind of negative connotation. But I do think it's important that parents are equipped with the best knowledge that they can have. But I would say I would prefer to skew that wherever we can positively, which isn't denying that there are negative things that we all see. But in terms of effective messages, I suspect it's going to be more effective.
I mean, one of the themes of the questions coming up, Paul, is how much people really appreciate and like the need for the approach that you're recommending, which is a well-being promoting activities, being part of what prevents rather than simply therapeutic or corrective interventions or treatments. One questioner asked whether you would include physical activity and opportunities for socializing and those kinds of things in these kinds of positive prevention interventions.
Yeah, absolutely. I mean, if we're thinking about young children now in the situation that we're in at the moment, one of the really detrimental things about the pandemic has been, particularly for very young children, losing the opportunity for a brief period of being able to go outside, run around, rampage, do whatever they do, but also playing with children their similar ages and having what is clearly a fundamental part of development, the things that you learn by interacting with your peers when you're very, very young. And, I was speaking to a head teacher last week, and he said the children coming into their reception class, the pre-reception class, the sort of 4-year-olds, have had nearly half their life under the cover of a pandemic, not always shut away, but shut away for significant periods or restricted. And they're noticing differences in how the children can manage those social situations in terms of interacting with their peers, but also how they manage that classroom situation with the teacher as well. So some children have clearly missed really, really important aspects of the development. And sometimes we only learn these things when things have gone wrong, as they have in the last couple of years. But I'm digressing a little bit, but to come back to the question, yes, absolutely. Physical activity, interactions with peers, play are all fundamental building blocks of a positive childhood, which we neglect at our peril.
2 questions about healthy start, happy start. And we need to be briefer about it. 1 simple question, what was the cost per child for healthy start, happy start?
Yeah. I haven't got it off the top of my head. There are 2 publications. There's a paper in JAMA Pediatrics that came out earlier this year, and then there's a report on the HTA library. Christina Farrelly and Beth Barker are the lead authors on that. That's got all of the cost effectiveness analysis. I think it's somewhere in the region of £1,000 to £1,500, but I'm plucking that from months ago, and that could be wrong, but the data's all there, so you can look it up.
Okay. Second question. How do you engage challenging families to participate in Healthy Start, Happy Start? How do you engage them in early intervention programs if they are challenging families?
Yeah. Well, in the trials, obviously a little bit different from sometimes from everyday life, but we thought very hard about the materials that we had that were presented to families. So the written and video materials that people could access to find out about the study and the intervention, and then really good, well-trained staff. I was very fortunate to work with some great people, and they were enthusiastic, positive, patient, able to explain the study in language that people understood. And that was, I think, the biggest difference, having those people working in the front line of the study.
Some questions that maybe take you out of your comfort zone, but do feel able to say if you want me to move on. Primary school, what do you think the most appropriate interventions might be in primary school for primary school-age children?
Particularly about mental health, or
yeah, I've been thinking mental health is the target. What can we do?
I'm not a teacher and I'm not an educator. So this comes with that really important caveat, which I think sometimes in mental health we forget. I work in the Faculty of Education, and goodness me, teachers are brilliant, and the training that they undergo and the work that they do is extraordinary. And I think because it's there every day and because we've all been to school, we forget about how precious and wonderful that is. So I'm loath to tell teachers what to do ever, and shouldn't. One of the pieces of work that we've been doing, we had to pause for the pandemic, was looking at working with reception class teachers to help children with that transition to school. So this is one point at which I think we can make a real difference. Those first days of school make a huge difference to how well children settle into school, particularly children with additional difficulties, perhaps neurodevelopmental difficulties or some behavioural difficulties. And we've been working using a variation of video feedback with reception teachers to help them to notice how children with these kind of difficulties communicate their needs. So that's one area where I think we can make a big difference, is thinking about the transition to school, particularly for children who find that very difficult. And we hope that will have an effect on their longer term trajectories. It remains to be seen.
One final question, Paul, if you would. What do you think are the dangers of medicalization, that turning problems that are existential into something that needs prevention, needs intervention? Are there things that we could do that would kind of change our attitudes to mental ill health, that would actually remove, as it were, the need for prevention, because we accept it more as part of life?
Yeah, no, I have. I mean, I'm a doctor, but I have some sympathy for the treating medical takeover of some fields, in particular mental health. But and that can take us quite a long way in a positive direction. The kind of well-being focus, the not pathologizing things, but at various levels, you've got people who are extremely distressed, and sometimes that's because of societal factors and community factors and family factors, but sometimes it's because of clusters of difficulties that we recognize as mental illness. So if we think about the most extreme, if someone can hear voices and manage it, that's absolutely fine, or manage it with support. But if someone is hearing voices that are persecutory and causing them enormous distress, then I think we have a responsibility to try and respond and help that person. It doesn't have to be a medical response, it can be a system response, a psychological response. But that's the bit that gets missed if we just go for the well-being, just go for the positive approach to things. I think it's important, I think it has value, and it can redress what has been a bit of a problem in the past, but we mustn't forget that there are some people who are devastatingly affected by mental illness, and we have to be able to respond to them.
Paul, thank you so much. There is in World Psychiatry, June, there is a brilliant systematic review on preventive psychiatry. I don't know whether you've come across it. I'm sure you would have done. Where the point that, having reviewed all the literature, the authors come to the same point as you've presented here, which is universal prevention is probably what will achieve what we have been singularly unable to achieve over the past 40 years of mental health, which is to impact on the prevalence of mental ill health across all kinds of advances, but we haven't really touched the prevalence. And I think what you are suggesting, Paul, is bringing us home and also bringing us major concerns around that hope, concerns about knitting together, integrating, which I think is an incredibly important point, but also points about weighing up those for whom the problems is clearest, but balancing it with the enormous number of people who are genuinely at risk, maybe, but normally wouldn't be aware of it. But if we do something that's generally preventive, we will actually make a difference. So I do think the point that you make is of enormous importance and value. And I'm so pleased that you made it in such an evocative and approachable and accessible way for everybody. People can fill in their feedback form, and they'll be sent, everyone will be sent one once the seminar has finished. I very much hope that you enjoy the seminar, which we deliver as part of our commitment to providing free and accessible events to those who support children and young people. And if you feel able to and you enjoyed the seminar, as I have done enormously, you can donate to the center by scanning the QR code on the screen now. But our next transformation seminar will take place on the 8th of December with another colleague, Professor Lewis Appleby from the Center for Mental Health and Safety and the Center of Women's Health, Women's Mental Health, the University of Manchester, talking about what he knows more about than anyone else, which is the prevention of suicide, maybe at a different end of the spectrum. Paul, let me just end by saying thank you. The feedback that you've received in the questions are overwhelmingly positive and kind, and reflect really the sensitivity that you bring to teaching and the sensitivity that you actually try and train your parents to bring to their children's education. Thank you so much, Paul. And thank you
very much, Peter. Thank you for the difficult questions, everybody.
Bye for now.